afternoon. Welcome everybody to this webinar. So I would like to welcome you to this webinar session on the role of microcatheter and dual lumen catheter in PCI. And it's my honor to have some great interventional cardiologists with me today. First of all, Dr. Yoshihisa Kinoshita from the Yohashi Heart Center. I think most of you know him very well. He's a CTO expert and he is dedicated to develop our interventionist skill. He has a lot of publications and presentations at scientific meetings, focusing on CTOPCI and bifurcation lesion. He has been in Thailand many times for CTO workshop, and we have learned a lot of technique from him. And secondly, my mentor, Dr. Ane Kanoksin, a well-respected CTO expert with a big volume of CTOPCI, huge experience. And currently, he is the hospital director of Central Chest Institute of Thailand. And then we have Dr. Watanyu Planet from Bangkok Hospital, Phuket. He is a very experienced CTO interventionist who was Dr. Kinoshita Fellow 8 years ago. And we are happy to have Dr. Purish Suranchupakorn from Central Chest Institute of Thailand. He is the rising star in both CTO intervention and structural heart intervention. So during this webinar, all of the attendees can join us by sending your question in the chat box or in the Q&A dialog box, and we will pick up your question, and we will get our speaker to answer all of your questions by the end of each section or each lecture. So please feel free to leave us your question in the chat box or in the Q&A box. So so let's begin with the first speaker, who will be Dr. Kinoshita, who will give us a lecture on the character and the roles of microcatheter in CTOPCI and its important. Then we go to the cases from Dr. Watanyu and myself. So Dr. Kinoshita, please.
Okay, thank you, Dr. Mianpage. Just a moment. Yeah. Okay. Can you see my slide?
Yes.
Okay.
Of course.
Okay. Today, I would like to introduce various characteristics of the Asahi's microcatheter. Does my slide move? It's okay?
Yes.
Okay. Okay, we usually use a microcatheter in the following situation. The first, as support device to keep the guide wire performance in the complex region. And then as a penetration device instead of the small balloon. And third, as device to exchange the guide wire instead of using the extension wire. So as you know, that now Asahi has various microcatheter as I show here. Among them, first of all, I want to talk about the toner family. So Thomas catheter have the same structure, which is made of the stainless steel like this. And they show high penetration force because of their stiffness, and they are useful in the calcified region, maybe especially. In this hot corsia, the calcified region is a good indication, as you know. So, in comparison with the Tornas catheter, the Corsia Pro or Cabell are most flexible 3P microcatheter because they have a hydrophilic coating from the tip to the 6 centimeter from the tip to the 6 centimeter proximal in Corsia Pro. And also in Cabell, from tip to the 70 or 80 centimeter to the proximal. So what is the difference between the Corsia Pro and old Corsia? Corsia Pro improved. The Corsia Pro is improved version of the Corsia by minimizing the stiffness difference between the tip and the shaft joint. So, so by changing this point, it's possible to improve the dramatically. This is a Corsia could not advance. But here, yeah, and this is a Corsia Pro. Yeah, Corsia Pro is yeah, Corsia Pro. It could advance easily because this stiffness is a little bit difference. Now this is a softer. This is the Corsia Pro. This part of the Corsia Pro is a little bit softer than the old Corsia. So it means it's very flexible. It is easy to pass in the torsion region like this. And the Carabel is so what is the difference between the Carabel and the Corsia there? Also, tip diameter is a little bit larger in Carabel, but the Carabel is thinner than the Corsia relatively. This is a Carabel or this is a Corsia. And also the Cabell is thinner catheter relatively among the similar catheter. For example, the distal shaft in Cabell is 62 and the turnpike is 74, Corsia 87. The proximal shaft also Cabell 85, the turnpike LP is 97 and Corsia 93. As you can see, the Carabel is a relatively thinner catheter. How do I use these different catheter? In Carabel, I prefer to use it in narrow or tortuous channel in retrograde approach. Corsia Pro, I usually use it in a large channel, or in the case which I need more pushing holes to advance it. Let me show my case. This case is hot is male. He suffered myocardial infarction 1 month before, and his common risk factor is diabetes and dyslipidemia. Ejection fraction is 37%. renal function is not so bad. As you can see, the RCA occurred, his RCA occurred proximal and already fixed. And the circumflex also occurred here. I could see tight collateral channel from the second diagonal to the circumflex distal. This time, my target region is the circumflex CTO region. Unfortunately, antegrade wide wire went in the subintimal space like this, and it was difficult to correct its direction. So I started the retrograde manner. Although XTR pass through this channel easily, like this, easily and smoothly. But just a moment. No, just a moment. Okay. Yeah, XTR could pass through this total channel, but this is a Corsair Pro. Unfortunately, Corsair Pro couldn't pass through this part because this channel is too tight and too tortuous for Corsair Pro. But as you can see, the caliber pass through this channel easily and smoothly like this. This is a caliber. Yeah, caliber advanced very smoothly, and it looks easily, even in the deep acute corner like this. Yes. So for such a tortuous, in such a tortuous and a tiny channel, tight channel, I think caliber is better. Next case is a 70s male. He also suffered the myocardial infarction 1 month before. His recurrent risk factor is diabetes, and ejection fraction to 43%. His renal function also is good. So his RCA probably that proximal, and there was a good collateral channel from the first septal branch, like this. After the antegrade preparation, I started the retrograde manner with XTR. XTR passed through the distal channel easily, like this. But unfortunately, the cowbell could not pass because of the weakness of pushing force. So actually, after the passing through this bend part, we could not advance cowbell catheter from this point to the distal. But Corsair could advance in this channel by pushing it with the rotation. So in the case in which we need some pushing force, at that time the Corsair is better because we cannot rotate the cable catheter in the tight channel. Recently, we got the new product. It's named the Corsair Pro XS in Japan. Yeah, in the treatment of CTO, we often face the situation in which we could think that microcatheter, which has both Corsair and cowbell characteristics at the same time, would be useful. The position of the Corsair Pro XS is just between the Corsair Pro and the cable. It has a small and a thin tip, and just between the Corsair and the cable. And also it has a rotational shaft. So the new microcatheter had both the cable characteristic and Corsair characteristic at the same time. Corsair Pro XS can pass through the very, very highly bending tortuous phantom vessel like this. In this phantom vessel, the Corsair Pro can advance up to here, but from here it could not pass to the distal. Cable also could advance up to here, but it could pass to this point to the distal. But new microcatheter Corsair Pro XS could pass this phantom border completely like this. So I want to show the Corsair Pro XS case. This case is a 60s male. His stable AP and coronary risk factor is diabetes and the ex-smoker. So his RCA occurred at the mid portion like this, and there was a good collateral from the circumflex to the distal of the RCA. And after the undergrad preparation, I started to the channel tracking with SAW 03 retrograde like this. So could pass this channel easily, but the cable could not pass this part because this part is a little bit tiny. So on the other hand, this is a Corsair XS. Corsair Pro XS pass through this part by rotating with this catheter, like this. So it's a very, very convenient microcatheter for us. I had the Corsair Pro XS will be introduced soon in Thailand. Maybe this catheter will be useful device, not only in CTO, but also usual the complex region. And finally, I want to talk about the Sasuke. So Sasuke has very unique structure. As you know, it has a double lumen in the same body. Now, one is a rapid exchange lumen, the other is over the wire lumen. And Sasuke helps to improve the accuracy of wire control in the complex region, like bifurcation or CTO, by stabilizing both guide wire position and the microcatheter position in the vessel. Yeah, please take a look at these videos. Now, when I use the Corsair on left panel, as you can see, the tip of the catheter and the position of the wire always moving during the wire manipulation, like this. Yeah, I try to select the side branch, but during my procedure, the tip of the microcatheter, the body of the microcatheter position of the wire in the microcatheter always moving. But on right panel, this is a Sasuke. During my procedure, tip of the Sasuke is very stable, and also its shaft, the position of the wire is very stable. So to keep the stable position is very, very important to control the wire in the complex region, like a CTO or bifurcation region. In addition, by putting the IBUS and the Sasuke side by side, like this, on the same wire, we can make the IBUS guided wiring system easily. I named this system slipstream technique. I will introduce some real slipstream cases. This case is 6 male. He is a stable AP, and his for risk factor is diabetes, hypertension, dyslipidemia, and ex-smoker. Ejection fraction is not so bad, and renal function is also not so bad. As you can see, he's already occluded at the proximal part here, here, and here. Yep. So I started there, and I started to advance the guide wire from the antegrade, from the antegrade. Yeah. And the wire, unfortunately, wire passed through the diagonal branch. Yep. So I confirmed using the tip injection, this microcatheter. Yeah, I can put this microcatheter into the diagonal branch, but unfortunately, I could control. I could not control the guide wire in the diagonal branch to the already main branch, because that is not subintimal space, but this guide wire advanced into the interplug, and after the ballooning of this diagonal in this part, we made a very, very thin wall in the already main branch. So I decided to penetrate this wall with a stiff wire by using the slipstream technique. After the setting, they're both IBUS and Sasuke on the same wire closely. I manipulated the guide wire and decided the direction of the penetration, looking IBUS image directionally. I will show the IBUS image. So as you can you see that this small wall, small membrane between this lumen and this lumen. Now you can see this is a stiff wire from the side hole of the Sasuke. Now I penetrated. I could penetrate this small thin membrane with this stiff wire. Yeah, let me show you again. This is a very, very thin membrane. This is a already main branch. Yeah, this is a stiff wire. I decided to the direction to penetrate, and then penetrate this membrane with the stiff wire like this. Now we can, yeah, we could advance this guide wire like this. So another case I want to show you. This is a 60s male. He has recently myocardial infarction. As you can see, his circumflex of fluid at the mid portion like this. Yeah. And unfortunately, the ultimate blood tree passed into the distal oil branch easily. Yeah, I checked the tip injection. I checked the portion of the microcatheter with using the tip injection. This microcatheter is inside of the distal oil branch, but I couldn't pass into the distal main branch because this wire went into the subintimal space from the beginning of the grid part of grid part. Yeah, I will show you this IVAS image. This is the distal oil branch. And now we can see the just a moment. We can see the, yeah, this is the main branch. But as you can see, this is the true lumen. This is the true lumen. This is the subintimal space. This is the true lumen. So my first guide wire, ultimate blood three, advanced into the subintimal space. This is the true lumen. So I decided to use the slipstream technique to get the correct lumen. I navigate the wire into correct lumen by using the direct IVAS information like this. So just a moment, as you can see, this is the second wire, and now, yeah, this is the true lumen. I control the second wire to the direction of the second wire to the correct true lumen like this, or angiogram like this. This is the first guide wire, and this is Sasuke. This is the IVAS catheter. Yeah. So then finally, I could get the distal main branch like this. And I have a image from the distal main branch shows this IVAS catheter pass through the center of the true lumen. Yep. So here I want to summarize about the position of each microcatheter. So Thomas family is specialized for the treatment of calcified region because of its high penetrating holes. Corsia Pro is good at occluded indication mainly because of its excellent crossing ability. Carbel is useful in the tortuous region and not so tough CT region also. And the Corsia Pro XS is well-balanced catheter, and it will be used extensively in many complex regions, I think. Sasuke is specializing for the region, including bifurcation or needed parallel wire technique in the CTO. In conclusion, there is no burst microcatheter at present. Each microcatheter has its unique characteristics. We need to get a lot of experiences by trial and error to know their real performance. Our role is to bring out their individual characteristics and promote them in the right place. Thank you for your attention. That's all.
Thank you very much, Kinoshita Sensei, for your great lecture. So I have a quick question for you.
Yep.
So what is the correct way to to use the corset? Uh, could we advance the corset by rotating in either direction or just clockwise rotation or anti-clockwise rotation?
Yes, thank you for your question there. It's a little bit difficult because in my experience, that I think that it's depend on the case. So usually I start when I need rotation on the corsair, and I usually start with counterclockwise rotation.
Counterclockwise mean
yes, usually I start with the counterclockwise, but in some case, with counterclockwise rotation, corsair hardly advance to the distance. In such a situation, I change the direction of the rotation from the clockwise rotation to the clockwise rotation. So it depends on the case. Depending on the case, I'm not how to say the direction of the rotation is completely different. So which direction is better to find which direction is better is very, very important when I use corsair.
I see. So so you mean clockwise is like this?
Yes,
and anti-clockwise is like this.
Yes, clockwise like this.
Okay, I see. And how about the carousel? Can we rotate or we just do the forward push only? The carousel.
So actually to say that Asahi's company people said to us never rotate the carousel. But in real clinical field, I usually rotate carousel a little bit, but not so quick, not so rapidly like the corsair. Usually when I rotate the carousel, I rotate very, very slowly. So when I use corsair, I rotate like this. But when I rotate the carousel, very slowly. So actually, in tortuous channel, a little bit tight and tortuous channel, I think that it is possible. It is possible to rotate the carousel, but once the tip of the carousel stick in the very, very hard region, like a calcified region, at that time never rotates the carousel. So when you rotate the carousel in such a situation, that in most cases the tip of the carousel easily broke. It is break, and often the tip of the carousel remain just in the channel or distal of the coronary artery. So the two, so the please don't forget to, not to much rotate the cable catheter.
I see. And one more question. So you know that the most common use microcatheters in the market are Corsair, Caravelle, and also some operator use of 5-cross. So please correct me if I'm wrong. So you recommend to use the Caravelle in the tortuous or vessel or tortuous channel, and Corsair when there is the bending part, or when you need more pushing force, right? So if one want to use a different kind of microcatheter like 5-cross, so when you use the 5-cross.
Yep. So thank you for your question. And so actually, as you know, the Caravelle and the Corsair is a very, very excellent microcatheter. But what is the weak point of the Caravelle and the Caravelle and the Corsair? Their weak point is the softness of the tip. So it means, as I said before, once the tip of the Caravelle or Corsair stick in the hard region, like a calcified region, it is easy to break the break of its tip. But on the other hand, the tip of the 5-cross is a little bit harder than the Caravelle or Corsair, and in some cases, especially the so calcified region, in the tortuous calcified region, the 5-cross often pass through instead of the Caravelle or Corsair Pro.
In the calcified region?
Yes.
Right. I see. So, and maybe we need more insight about the slipstream technique, but maybe I will ask you later in after Dr. Ane presentation about Sasuke. So we will ask you later. Please go ahead.
Dr. Kinoshita, may I ask you one question, please?
Okay.
What is your first choice for selection microcatheter in the retrograde PCI?
Yeah, so recently my first choice is the Corsair Pro XS. Yeah, it's a very, very convenient catheter. Maybe you will get it soon. Yeah, I had the Asahi company people. It will be introduced soon in Thailand. You know, it's a very, very convenient catheter.
Thank you.
Okay, so thank you very much for Dr. Ane question and for Dr. Kinoshita lecture. So shall we move to the case presentation?
Yep.
Yes. And so the next speaker would be, the next speaker would be Dr. Vatanyu Planet from Bangkok Hospital, Phuket. So he will give us a presentation about the CTOPCI and the usage of the microcatheter. So please, Dr. Vatanyu. I'm sorry.
May I share my screen?
Yes.
Good afternoon, Dr. Kinoshita, and all staff and all audience. I would like to thank you to Asahi Tech Company to give me an opportunity to present my case. This is a case of Thai male, 68 years old. The first time he present, before this time he had an appointment to perform CTOPCI, but the first time he presented with acute posterolateral wall STEMI with cardiogenic shock and heart failure. From the angiogram of the first time, you can see that there was block at ostial circumflex and proximal RCA and severe stenosis, diffuse stenosis of our LAD. So first time I decided to fix the circumflex first to fix the culprit lesion. You can see after that he had severe pulmonary congestion. He had to intubate with the ventilator support and intra-aortic balloon pump. But finally, he could be discharged after 10 days after the heart attack. And the second session, I tried to fix the LAD lesion, but at that time, only the wire could pass the lesion, but other device could not. Although I used a very small balloon or tonus microcatheter, all could not pass it. And unfortunately, I made the wire slip out. And when I tried to pass the wire again, there was some dissection and extravasation of the LAD, but it healed itself, so I stopped that at the time. But before I stopped it, I checked for the retrograde septal channel to prepare CTO, to prepare to perform RCA lesion next time. And I think I have to fix LAD with protablator, but I think it's better to fix CTO-RCA first. So at this time, I made an appointment to perform CTO-RCA after I fixed LAD. After I fixed LAD for 3 weeks, and with the balloon only at the proximal LAD, and then 3 weeks later, I start to perform PCI to CTO-RCA. You can see that the proximal LAD have more flow to the distal part and more good flow to the septal channel. So at this time, I use Hyperion AL1 side hole 7 French of Asahi and 4 engage RCA and EBU 7 3.5 to engage left main. Because the Hyperion AL1 did not support my device well, so I have to use anchoring balloon to the conus branch with sprinter balloon 2015. I inflate at 8 bar, and although I use this anchoring balloon, but the Xion Y or Filter XT with the 5-cross microcatheter could not pass the lesion. So I changed the Y to Gaia Next 1, but Gaia Next 1 could pass only the proximal lesion, but it could not penetrate to the distal part of the CTO part and ran out of the track. So the next step, I think I have to perform the parallel wire technique. So I prepare the space with the Sapphire Balloon Pro 1.0 and Sprinter Legend Balloon 1.5 to make a space for Sasuke double lumen microcatheter to perform the parallel wire technique. I use the Gaia Next 2 for the parallel wire technique, but Gaia Next 2 still could not reach the distal RCA lumen. So I switched from Sasuke microcatheter to Caravelle microcatheter for more better control, and I hope that Caravelle microcatheter could be passed more distally, but it still could not pass more distally. And the Gaia next to Y still could not reach the RCA lumen, distal RCA lumen. So I decided to switch to retrograde approach. You can see that the Gaia next to could not be controlled to the distal part of the RCA, to the true lumen. So I performed the channel selection. I used Xion with the retrograde Caravelle microcatheter 150 centimeters to insert to the septal branch and check for the retrograde channel. After confirm with the tip injection, I used 03Y and advance it to the septal channel to the distal part of PDA to the RCA, and then advance to the mid RCA. After that, I advance the retrograde microcatheter to the mid RCA. Quite easy. And then I changed from 03 to Gaia next to, and then I control Gaia next to Y to the mid part and to the proximal part of RCA along the antegrade Y. But however, the Gaia next to retrograde Y could not be controlled to proximal RCA. It ran out of the RCA, but the overlap range between antegrade and retrograde Y, it was enough for reverse card technique. So at that time, I used a small balloon that was Sapphire Pro 1.2 and Sprinter balloon 1.5 in the antegrade Y to dilate the mid and distal part of RCA to make the space for IVAS to confirm the antegrade Y was in true lumen and to perform the reverse card technique. But unfortunately, I could not show an IVAS because the image was deleted from the machine already. From the IVAS, it showed that antegrade Y was in true lumen from the proximal to mid RCA. So I start to perform reverse card with the Sprinter balloon 2.515 inflate at the mid part of RCA, and immediately after I deflate the balloon, I advance the Y more along the balloon when I deflate. You can see that when I inflate the balloon from the right, I inflate the balloon and then deflate immediately and pass the Y through the space after the balloon dilatation. And finally, I try to advance the retrograde microcatheter of the Caravelle to the proximal part of RCA. And I try to control Gaia next to Y to the antegrade guiding catheter, AL1, but it was not, it could not be performed because of the stiffness of the Gaia next to. So I changed the Gaia next to Xion Y, and finally I could control to the antegrade catheter. And then after I could pass the Y into the antegrade catheter, I use the balloon to trap the Y, and then I push the retrograde Caravelle microcatheter to the integrated guiding catheter. You can see that when this retrograde microcatheter was pushed into the integrated guiding catheter, and then I changed Xion Y to RG3, too long RG3, and then advance the integrate, advance the Y to another side of the guiding catheter, and perform XY externalized technique. And then after that, I perform. I put three of the stent along the RCA, and after this is the final result that I performed the PCI to CTOPCI. This is the left scene is the before, and the right picture is the after PCI. And 4 months later, I performed PCI to LED with the rotablator. And this is the final result of the LED. So for this case, I used the first time because poor backup support from AL1 guiding catheter. So I have to use a balloon anchoring technique. And after I could not perform integrate PCI, I tried to change to use the double lumen catheter of the Sasuke to use the parallel wire technique. And when I failed to perform parallel wire technique, I start to perform retrograde PCI by the septal to use the retrograde septal channel and pass the retrograde Gaia to the mid RCA and try to pass it along integrate Y with the kissing Y technique. But after that, I failed to control the retrograde Y, so I start to use the reverse card technique with the IOS confirmation, and then finally I use the Y externalization. So in this case, IOS is very useful to perform the proper part to perform reverse card technique, and the retrograde carvel is very useful to perform the retrograde PCI, because I feel very slippery of this microcatheter. And the precaution when we pass the retrograde Gaia next to the proximal part of the RCA, we have to be aware that the retrograde Y will run into the subintima and may cause dissection of the osteo RCA, and it may cause side branch loss, especially SA node branch or conus branch. And when I finish the procedure, routinely we have to check the complication of the in the retrograde channel, that we have to remove the retrograde microcatheter and confirm angiogram to see that there was not perforation of retrograde channel. Thank you for your attention. ขอบคุณครับ ครับผมขอบคุณครับอาจารย์เหมือนเพชรอาจารย์เหมือนเพชรได้ยินไหมครับ
ครับอาจารย์ Thank you very much for your kind presentation. I have a question for you and for Shinoshita Sensei. So in your case, you use the parallel wire technique, and you use the Sasuke, you use the dual lumen catheter. So my question is, so I know that currently, or when we perform the parallel wire technique, we many operators prefer to use the dual lumen catheter more than two microcatheter, right? And so my question is because in dual lumen catheter it's like a rapid exchange system. So one wire is in the lumen like over the wire system, but one wire is in the rapid exchange system. So my question is, the wire that is in the rapid exchange system is the control is equal or comparable to compare with using a two microcatheter. Can you understand my?
Okay, I think if you use two microcatheter, it will need more space than only one catheter. And another reason that that Sasuke or double lumen microcatheter is better, I think, because one wire will be the main make more stable when we control another wire. But if we use separate microcatheter, the other microcatheter can be moved during the talk, or we control the microcatheter so it may be less stable than we use double lumen microcatheter.
Yes, but we, in my understanding, we could not advance the Sasuke until the wire can enter the distal true lumen, right? I mean that we could not advance because one wire is in the subintima or something, so we couldn't advance during the wiring of the other wire until we can get to the distal true lumen, right?
Yeah, but mostly in the situation that we use the double lumen microcatheter, we need more stable of the support catheter, because usually it's quite a tight small lumen. If we use a bigger lumen, if we use two microcatheter, may be difficult to advance each microcatheter forwardly. You understand what I say?
Yeah, I see.
Yeah, actually, when I use a Sasuke double lumen catheter, so the wire in the over the wire lumen, when I use the wire in the over the lumen, its wire is very controllable. But the rapid exchange lumen, that wire is not so controllable. So usually the situation in which we want to use the Sasuke double lumen catheter, the first wire usually in the subintimal space. Maybe that wire is used for the rapid exchange wire lumen. And the second guide wire from the over the wire lumen is that wire is for the selection, so the select to the true lumen. So actually, in the double lumen catheter, when I use the double lumen catheter, we ask the which wire is important for us to control or to penetrate the distal to lumen is over the wire lumen wire in the over the wire lumen. We don't need to control the wire in the rapid exchange wire. Yeah, and and another your question, the one more question is once the wire pass through the distal to lumen, at that time actually it is impossible to advance the Sasuke double lumen catheter like a usual microcatheter. So at that time, after the passing the wire to the distal to lumen, we have to exchange the microcatheter from the Sasuke to the usual microcatheter, like fine cross or Corsair or Capel. Is it okay?
Yes, but so until the wire can get to the distal to lumen, we can advance. But before that, we could not move the Sasuke microcatheter forward, right?
Yes, that's true. Actually, when I control the if once the second wire can get the distal to lumen, but at the entry point, we can get distal to lumen, but the second wire could not pass completely to the distal to lumen yet. At that time, we have to change our microcatheter to the usual one during the procedure.
I see. Thank you so much. So, if there are any question, please put in the chat box. So, even this is the Asahi webinar, but the goal is highly educational. So you can ask any question about the CTOPCI, not just related to the Asahi product. So feel free to leave your question here in the chat box. So the next presenter will be myself. And okay, so let's start. So this is a case of a 59-year-old male who presented with non-FC elevation ACS. He has good renal function and quite good aviation fraction. So the angiogram shows severe stenosis in the proximal and the mid part of RCA. And there was the critical stenosis in the proximal part of LCS and also the distal part of the vessel. And you can see that there is a total occlusion of mid-LAD, which receiving ipsilateral collateral channel, the septal to septal. And, this is the angiographic summary. So he has a 3-vessel disease with CTO at mid-LAD, with distal vessel filling via ipsilateral septal to septal collateral, and critical stenosis in the proximal and distal part of RCS, and severe stenosis in proximal and mid RCA. And syntax score is quite high, and by the anatomical complexity, we should recommend him CTOPCI, but the patient refused and opted PCI. So let's review of the anatomy of the CTO. So this CTO had ambiguous proximal cap and ipsilateral septal collateral channel. I'm sorry. From mid to distal LAD with the JCTO score of 2 with the entry and the length. And another difficult part is this diffuse small distal to lumen. And because the cap is ambiguous to me, I'm not sure which is the entry of the CTO, this one or this one. So according to the APCTO algorithm, if we have the proximal cap ambiguity, we should do the CTOPCI entry to see the entry point of the CTOs. So I put the wire in the septal branch and I do the CTOPCI pullback. So you can see that this is the proximal cap of the CTO coming here. So I do the CTOPCI marking. So now I know that this is the proximal entry, and I have to penetrate here. So I do the anti-gate puncture with Gaia second, and I use the 5 cross as the anti-gate microcatheter. After that, I did the CTOPCI to confirm that the anti-gate wire has engaged into the intimal plug. So this is the still image. So you can see that the anti-gate wire was in the center of this circle. So it's likely to be in the intimal plug. So then I advanced Gaia second further into the CTO body, but unfortunately the wire went into the subintimal space. So what should I do next? So because this vessel has poor quality of this vessel, and there is the interventional collateral present in the septal branch, so I prefer to use the retrograde approach now. So I did the tip injection by the Corsair microcatheter. So this septal collateral channel is quite tortuous, but I think the size is usable. So I use the Xiong wire to pass through this septal channel, and I can advance the Xiong wire into the distal to lumen. And this is the retrograde Corsair, and I leave the anti-gate 5 cross microcatheter as a landmark. And I try to do the direct retrograde wire crossing, but failed. I switched to directed reverse cut using a 1.5 millimeter balloon, but failed also. So next, so after I failed the directed reverse cut, and so we should do the conventional reverse cut and anti-gate examination. So I dilate the vessel via the anti-gate guide wire, and I did the CTOPCI study. So you can see that the anti-gate guide wire went into the subintima, and here the retrograde guide wire is in the plug. But from here, the retrograde guide wire went into the subintimal, the same space as the anti-gate guide wire. And I would like to summary like this. So here you can see that the retrogate guide wire is in the left side and the anti-gate guide wire is on the right side. So that means that we look from this view. So this view is the view that you look in the angiogram. So the retrogate wire is on the left side and you get on the right side, and here the wire cross each other, and here the retrograde guide wire is in the intimal plug. The anti-gate wire is in the subintimal, retrograde in the plug, anti-gate in the subintimal. But I'm sorry, I could not see my screen here. Okay, and here the retrograde wire moved to the right side, and anti-gate wire on the left side. And here, around here, the retrograde wire went into the subintimal space, the same space as anti-gate wire. Here we can see anti-gate wire in the lumen, and here anti-gate wire in the lumen and the retrograde wire in the septal branch. So in this direction, we are looking at this picture. So the best position to make the connection is here, because two wires were in the same space, and we can keep more proximal, more intimal plug tracking in this segment. So around here is this situation. Both wires are in the subintimal. So I make the connection by using a 2 millimeter balloon inflated here, and I puncture with the Gaia second, and then I can advance the guide wire into the guiding catheter, and I trap retrograde wire with a 2.5 millimeter balloon, and then I can advance the crosshair into the guiding catheter. Then I dilate and I push in the anti-gate wire into the distal main vessel, because you can see that the distal vessel also have a diffuse disease. So I put in the anti-gate guide wire, and then I remove the G3 and both retrograde and antegrade microcatheter. I did the tip injection to check for the collateral injury, but no injury. Then I put 3DS from distal LVD to proximal LVD, and this is the final result. So in summary, in this case, I started with the IWAS to identify the proximal cap of CTO. Then I use IWAS to guide a penetration of the cap to confirm the intimal plug position of the anti-gate guide wire. And after the anti-gate wire went into the subintimal space, I switched to a retrograde technique with using equilateral collateral channel. And when direct retrograde crossing and directed reverse cut fail, I perform IWAS guided reverse cut, and then I do the externalization technique. And because this session is about the usage of microcatheter, so I want to discuss my point of view about the microcatheter selection in my case. So I use 5 cross as the antegrade microcatheter, because I think the proximal segment of the vessel has a severe stenosis. And in this case, I need to put in both IWAS and educate microcatheter for the puncture of the CTO entry. So because the 5 cross has a lower diameter, so I select 5 cross to prevent the ischemia to the vessel, and also I need to visualize the distal to lumen here by educate injection through the microcatheter and through the ipsilateral collateral channel. So because the 5 cross has lower diameter, so it can be better visualized distal vessel, I think. And why I prefer Corsair microcatheter as a retrograde microcatheter in this case, because you can see that there is bending of the septal like a V shape. So I think to the torque transmission of the Corsair, it can facilitate a better retrograde septal channel crossing. And when I perform the retrograde technique, I don't need the contrast injection from the microcatheter from the guiding catheter anymore, because I have the landmark. I have the microcatheter as a landmark, so I don't need an injection anymore. So I can use the Corsair, I think. So, and this is my presentation. That's all. So, can I have your comment, please? So, can I have your comment?
Yep. Thank you for your nice presentation. Yeah, I will have some question in your procedure. Is it okay? So
Yes,
in the reverse cut, at the first reverse cut, which size of the balloon did you use? Only 1.5 millimeter balloon only?
Yeah, only 1.5 millimeter.
Yeah, actually, when I saw your IVAS image, you explained in detail. At that time, maybe the vessel diameter in the LAD almost 3.0 millimeter. So, yeah. And at the distal, of course, so your procedure is very excellent, and but I think that you can use a little bit more larger, size balloon, like a 2.5 or 3.0. So to using the little bit the larger size balloon, I guess it will be it may be easy to make a connection.
Yeah, I see. Thank you for your comment. And I have a question. So when for this procedure, do you think it's better to use two guiding catheter like a ping pong guiding catheter? Is it more safe?
Maybe I choose the two guiding catheters in this case. But one more question. You explained that after the externalization, you trap the wire in the 2.5 balloon in the guiding catheter, and then advance Corsair.
Okay, Corsair, yes.
But Corsair is in the same guiding catheter, right?
Yeah, so that is my point. So because some doctor told me that maybe it's better to use two guiding catheter.
So I think that it is a little bit difficult to push the
Crosshair.
crosshair
Yeah,
during
I
the push.
think so. Yeah, but at the time I use only one, but I have got some comment
Mhm.
to use two guiding catheter. Maybe it's better.
Yeah, so actually, in only one guiding catheter system, it is difficult to get the backup support after the making the externalization system. So when you use ipsilateral channel for the retrograde approach, at that time to guiding catheter system is better, I think.
May I ask two questions about Wenpek Sensei and Dr. Kishimoto Sensei? How can you choose the balloon size and length for the reverse card technique according to the IVAS? Because the IVAS sometimes is in the subintimal, and I don't know what is the exact size of the EM of the anticate vessel. And the second question is, which wire that you suggest to use for little gate puncture to the anticate lumen?
Yeah.
Okay, so maybe I try to answer first, and maybe Shita Sensei can correct me. So I think we can select the balloon size according to the vessel size, like just proximal or distal to the subintimal space. So we can estimate the vessel size, and I think the maximum balloon size that we use should not exceed the vessel size, I think. And for the guide wire, maybe Dr. Kinoshita can give us the more better answer than me, please.
So could you show me your presentation again, especially so you make your slide in which you show the IVAS image and relationship between the antegrade and the retrograde guide wire. Yes, that's right. Yeah. So,
which one? This one or
this one?
This one.
This one.
Okay.
Yes. So actually, if you make the connection in the frame 157 in this part, in this position, that if you want to make a connection, at that time you should choose the you should decide the balloon size just the same as the distance between the antegrade and the retrograde wire. Distance between the retrograde and the antegrade wire. So maybe this case that
like this.
Yes. Maybe so. Yeah, and actually the frame 271 also you should choose the same length with the distance between the retrograde and antegrade wire. Yeah, so to use the 2.5, maybe 2.5 or 3.0, I'm not sure that to use the more than the 2.5 balloon, maybe this subintimal space from the antegrade will be compressed and it is easy to control the lateral wire to penetrate the antegrade horse lumen. So actually, in this situation, if there is some space from the antegrade subintimal space, it is difficult to make a connection from the retrograde because the retrograde wire usually retrograde wire usually they cannot transmit its penetration force because of the residual space from the antegrade. So when we usually make a penetration from the retrograde to the antegrade, at that time at least we should close the residual space from the antegrade subintimal space using the little bit large size balloon. So, in such a situation, which wire is better to making a penetration? We usually need a little bit stiff and more controllable wire, like Gaia family. Actually, so Confiance Pro or Confiance 12, it's such kind of a wire is very, very stiff, but it's a little bit difficult to control its direction. So maybe I recommend to making when I make a penetration a connection to penetrate by penetrating this space, the Gaia second, Gaia third is better usually.
Thank you very much.
You're welcome.
So maybe it's better to have some physical break for 2 or 3 minutes. Are you okay with that? So we will have a break for 2 minutes, and please come back after 2 minutes, and we will have a lecture from Dr. Annie. So please come back.
อาจารย์เหมือนเพชรขอถามนิดนึงได้ไหม อยากรู้ว่าตอนที่อาจารย์ทำ external line mesonym guiding เนี่ยเอาคอแซหมุนโดยบอลลูนแท็บมันหมุนได้ใช่ไหมเป็นภาษาไทยนิดนึง
มันหมุนได้คือที่เข้าใจว่าตัวresistance ระหว่างบอลลูนกับคอแซกับบอลลูนกับ Y มันไม่เท่ากันคือresistance ระหว่างบอลลูนกับ Y น่าจะมากกว่า resistance ระหว่างบอลลูนกับคอแซก็เลยทำให้มันยัง advance สามารถ advance คอแซได้โดยที่บอลลูนมันยังขัด Y อยู่คิดว่าอย่างนั้นแต่ว่าคืออาจารย์หลายคนเขาจะบอกว่าให้ใช้เป็น2 catheter เป็น2 catheter ดีกว่า
หมุนเนี่ยกลัวมันวายมันหลุดออกมาด้วยตอนหมุนเข้า
แต่ก็พี่คิดว่าปิงปองน่าจะเซฟกว่าปิงปอง catheter น่าจะเซฟที่ได้แบบคอมเมนต์จากอาจารย์หลายๆท่าน
ขอบคุณครับ ท่านเหมือนเพชรมันมีคำถามให้อาจารย์นะครับว่าอาจารย์ใช้ไกดิ้งไซส์เท่าไหร่อะครับ
7 เฟรนครับ
7 เฟรน
เขตเมื่อกี้ใช่ไหมครับ7
ครับผม
So shall we start now? So next let's start with the lecture from Dr. Anek Sin. He will hear.
Unmute, please.
Okay. So next, can we move to the lecture by Dr. Anek Sin? He will talk about the supported system in the PCI. Dr. Anek, please.
Thank you very much. Good afternoon, all panelists and audience. My topic today is I will focus on the dual lumen microcatheter in CTOPCI, and the topic is how can the support system help you succeed. I will focus, my presentation will focus on Sasuke microcatheter, and the scope of the talking is about the concept of the Sasuke and characteristic and application of the dual lumen catheter. What is Sasuke? Sasuke is a name of the famous Japanese ninja. It means that it's a precision and accomplishment. So how do we stabilize the guide wire with the Sasuke? So in the bifurcation or CTO lesion, we have 3 main uses of Sasuke. The first is for the bifurcation CTO and the CTO at the sideband. Just fix the microcatheter at the by pressing it before the lesion at the bifurcation, via the rapid exchange guide wire port, and then use the OTW port with using the CTOY to cross the lesion. And the second is for the main band CTO, the distal main band CTO, just fix the Sasuke at the sideband over the monorail rapid exchange guide wire to increase the penetration power to cross the region. And the next is for the CTO region. You just fit the Sasuke microcatheter inside the CTO and over the subintimal, the first wire in the subintimal space, and then use the second wire over the OTW channel port to cross the CTO region to increase the control of the CTOY. So for the complex bifurcation CTO, this is a video demonstration when you use the single lumen microcatheter to cross the CTO of the side branch. This have not good enough support to cross the region. To compare with the dual lumen microcatheter, this is a rapid exchange wire, and this is the Sasuke tip at the over the OTW port to cross the sideband. It had a good stability and support for cross the region. And for the sideband anchoring technique for the main band CTO, when you have the main band CTO and have a bifurcation, you can just cross the sideband with a Y over and then use Sasuke for the sideband with the rapid exchange port and use a CTOY to cross on the OTW port to cross the CTO region like this. This is a front view. And let me explain about how to use a subintimal anchoring technique for the CTO region. Because of the Sasuke have different ports, so it's not exactly to use the parallel wire technique in Sasuke because the rapid exchange port is not good enough support to control the guide wire. So just use the, this is the demonstration of when you pass the guide wire, the first wire went into the subintimal space like this. So you change to the Sasuke microcatheter over the rapid exchange port here and put the guide wire in the CTO region, and then you can use the CTOY to cross in the OTW port to cross the region. So this is not exactly the parallel wire technique. This is just so-called a subintimal anchoring technique. So why do we need a Sasuke for bifurcation CTO? The reason is for stability because of Sasuke can be anchoring by using the rapid exchange guide wire and enhance guide wire controllability to withstand the counteractive force. And for the controlling, you can change the entry point by using the CTOY over the OTW port and use it as a pinpoint for the target region. So this is two of the reasons that why we need to use Sasuke. And the next scope is the characteristic of the Sasuke. The Sasuke have two lumen. One is a rapid exchange port. This from the tip up to here. This is a rapid exchange port. And the second is the exit point of the OTW port from this to the proximal hub like this. So it means that from the tip of the Sasuke to the OTW exit point is about 6.5 millimeter. So it's very short. And the usable length is longer than other dual microcatheter because of it's 1,450 millimeter. And the widest part is about 3.5 French, but the shortest part is about 2.5 French. It's not the oval shape, not the round shape, it's an oval shape from the cross-sectional. So the superior of Sasuke, the first is a tip comparison. You can appreciate from the fluoroscopy that the Sasuke have the shortest compared to the tip at the axis of the OTW port. And it's really precise because of you can know that where is the point of axis of the OTW port compared to the other competitor like cruises or twin pass or enhancer is have a longer tip, and sometimes we cannot know where is the axis of the OTW port like this or like this. So this is we can know that quite exactly from the Sasuke. And for the length compared to the competitor, the usable length of Sasuke is longer. It's 145 centimeter compared to the cruises 140, and twin pass and enhancer is about 135 centimeter. The second is about the lubricity. Because of the Sasuke coat with the long-lasting coating, lubricity coating, so it's quite durable for us to have a sliding resistance. So you can slide it up to 50 times to still have a slippery property. So compared to the competitor, the Sasuke have a more slippery compared to the cruises or twin pass or enhancers. The third is Sasuke have a double stainless steel core to maintain high king resistance. And the first core is from the proximal end to the distal near to the exit point of the OTW port. And the second core over here at the shaft, so it means that it's quite high maintain of king resistance compared to the other, like the cruises have only one core of stainless steel, and the twin pass only one, and the enhancer is have two core but it's shorter than Sasuke. And the fourth is the oval shape design. This is the unique design of the Sasuke compared to the other competitor because it has an oval of the cutting the surface, and the vignette, the most vignette is about 3.5 French, and the shortest is about 2.5 French. For the concept of oval shape design, so when we operate in the reservoir, it can be stabilized like this. Compared to the round shape design, it's maybe not quite stable. And this is the bend test from the experiment. Sasuke, when you use the Sasuke, and when you put the guide wire advanced, it has some resistance to put the microcatheter just only break, just only back. But compared to the other competitor, not only the back, it's also rotating. But the Sasuke is not loaded, so it's quite stable compared to the other competitor. And again, because of the oval shape design with equalized thickness, so it's quite more have a resistance to prevent sharp perforation, especially when you use the very stiff wire like a concrete A20. This is some of perforation in the of the cruises microcatheter, not in at the exit point. It's just a perforation at the shaft. So this is sometimes we face with very difficult to do it when you use the very stiff of the guide wire. But the Sasuke can be used very stiff wire. And for the visibility, you can, this is compared to the competitor. Sasuke can be more visible because of the opacity is you can sure that this is the tip of the rapid exchange, and this is the exit of the OTW port. So it's a very quite visible for operator to do the case. And the sixth property is the taper tip. So this design is increase the trackability. When we face with unsmooth surface of the lesion, it can be tracked and cross the lesion like this. And this is the compare between the competitor. The Sasuke has a superior of the trackability compared to the other competitor. And how to remove, after we use the Sasuke, how to remove the Sasuke. Actually, for the technique to remove, we have many techniques like for guiding extension wire for remove the dual lumen catheter, modify Nanto technique, and the trapping balloon. This is demonstrate how to do the trapping balloon to remove the Sasuke. Just be caution, do not trap over the tip of the the Sasuke because it can be broken. So after you tap distally to the Sasuke, and then you can remove. And when we use the guiding catheter, the regular guiding on the right hand side, for the 6th vein, you cannot use a regular balloon for tapping because of the profile is not compatible. So if you want to use a Sasuke in 6th vein and want to remove it trapping, you can use the trapper balloon. So the trapper can use up to from the 6th vein, but for the regular balloon, you need to use in the 7th vein. And for the guide liner or guide extension, you can see that even the trapper cannot use in guiding extension for 6th and 7th vein. And for the regular balloon, you cannot use for when you use the guide extension. The next is the application, how to apply to use the Sasuke in the many variety of the cases. The first is to do selective injection because they do all microcatheters, so you can do the tip selection over the OTW port for to do selective angiogram, to do a reverse Y, like a crusade. You can do it like a crusade. Make the tip of the guide wire as a hairpin like this and do the cross the sideband, the acute anchorated sideband like this. And the next is the routine that we use for sideband access to cross the stent stud. Just advance the crusade beyond the stent and then draw it back below, just proximal to the sideband, then advance guide wire to the over the OTW port. And sometimes you need to access the sideband occlusion like this. You can use the Sasuke to just the axis point of the OTW face to the lumen of the sideband, and then use this wire to cross the lesion like this. And sometimes your port face to the opposite side, opposite direction of the lesion. So you can just draw the Sasuke back to proximal of the lesion, and then you get when the wire cross the sideband lesion like this. And sometimes we need to do the CTO at the bifurcation, and we need to protect both band. So sometimes when we cross the CTO lesion with one Y, and we need to protect this band to prevent the gel of this band. So when you cross the Y with a single lumen catheter, then you change to the Sasuke and draw it back to until the axis point face to the sideband like this, and advance the second Y over this to cross to protect the side branch. And this is how to do this anchoring technique, because of sometimes the entry point of the CTO is really hard. So you can use Sasuke to do the sideband anchoring like this, and use the CTOY to cause the very hard of the proximal cap lesion like this. And this is how to do the subintimal anchoring technique. When your first Y with a single lumen catheter crossed into the subintimal space, you can change to the Sasuke and put it inside the CTO lesion, and then use it as an anchoring to support the Y, the CTOY in the OTW to cross the lesion. So this is a case demonstration. To be honestly, this case is not my case, but it's really good for demonstration. The indicate RCA CTO. The first Y is went into subminimal space like this. And then you just remove the microcatheter and change to the Sasuke microcatheter. To do, and just a little bit advance into the inside the CTO and use this and use the second Y of CTO guide Y. This is the second guide first. Try to do like a parallel Y technique, but it's not a parallel. Actually, it's not a parallel because this Y is in suboptimal space, so it's used as for anchoring, not for the parallel technique. And then we can use the second Y to pointing to the two lumen. And after that, we use the first Y as a marker. After that, for the first Y, the second Y can cross the lesion like this, and then you can advance the second Y cross to the two lumen. And this is a final angiogram. And how can we use the Sasuke for retrograde approach? For the retrograde approach, you can use as for the tip injection and access to the collateral channel. This is the first Y to cross the collateral channel, but it cannot cross to the retrograde channel. So you can use a Sasuke for tip injection like this, and then use a second Y for access to the other band. And when you have to do the retrograde bifurcation lesion to cross the CTO, you can use Sasuke as the anchoring for the crossing to the CTO lesion retrogradely. When your Y is to this one, and then use a Sasuke face to the CTO size like this, and then the second Y can cross to the CTO retrogradely like this. This is the second case for demonstration of the how to can we do the retrograde CTO using the Sasuke. This is a distal RCA CTO with have just proximal to the bifurcation like this. So we can use for tip injection, and then the guide Y cross the septal channel cross to the bifurcation lesion like this, and then we change to the Sasuke. And after that, together with Sasuke with Xiong close to the lesion like this, and then use the second Y to, this is a tip injection, and use the second Y to cross the distal CTO with the Xiong back to cross the lesion. And this is after we can cross the lesion. And final angiogram. So the conclusion is Sorry, because the slide is stopped. So it's my last slide is also the same as so this is the last slide. You can use, you can apply to use the Sasuke as many applications like I already presented. And the last is maybe the newer technique that Dr. Kinoshita has presented to use the new technique together with the IWAS guiding. Thank you very much.
Thank you very much, Dr. Anek. We have some questions from the audience. Also, we have a question from Dr. Viraj about the retrograde wiring using Sasuke. I think you already mentioned in your lecture about using Sasuke for the tip injection and selection of the outer collateral branch. But could you give us more tips and tricks about this? So after you do the tip injection and you can pass the wire into the selected branch, you take the Sasuke off and you switch to the regular microcatheter on or not?
Sometimes you need to use a selection for crossing, like the picture that I demonstrated, and then you can switch to the single lumen catheter again, and can do it. If the collateral channel is big enough, maybe you can use a Sasuke as a microcatheter.
And if it's in the case that there is the bifurcation just after the CTO segment, we can use the Sasuke for the anchoring technique for
Yes.
the retrograde puncture.
Yes.
And after that, change to the microcatheter again, right?
After that, yes, change to microcatheter again, and then do as a regular fashion, like Daiwa externalization or Londowood technique.
I see. And so may I ask Dr. Kinoshita right now about the slipstream technique? We have got a lot of questions about this. So let me start first. So in the slipstream technique, you use the same guide wire for the IWAS catheter and the Sasuke microcatheter, right?
Yeah, that's right. Usually, first we insert the microcatheter on the first wire, and then I advance the Sasuke using the same wire.
And what is the advantage of using the same guide wire compared to using another guide wire and put in the Sasuke on another guide wire?
Yeah, so usually when I use IBUS guided wire manipulation technique in the CTO region, first we advance our fast wire, and then maybe that's with the support any other microcatheter. But unfortunately, the fast wire migrates to subintimal space. And then, so in that step, as a next step, usually we try to perform the IBUS guided wire manipulation. But to do that, once we pull back the microcatheter and then advance the IBUS catheter. And to navigate the guide wire into the true lumen, we have to advance another guide wire. At the, so the how to say that, by using another microcatheter. But in some case, in the step of that, the second guide wire sometimes migrates another subintimal space. Or in some cases, it may be difficult to trace the same lumen of the first guide wire. And so before construction of the IBUS guided wiring system, in some cases it may take a lot of time. But using this slipstream technique, we usually advance IBUS catheter on the fast wire, and then also we can use the same wire to advance another microcatheter for choosing the correct wire lumen. So it's very convenient to to making a system with the IBUS guided wiring system.
I see. And what kind of IBUS catheter that should be used for this technique?
Yep. In my experience, both turns opticross and thermal IBUS is better. And but the thermal IBUS, we need 8 French guiding catheter, but most of the IBUS, it is enough to use enough for the 7 French guiding catheter.
I see. Okay. So let me check if there are another question about this. So okay, I think you already answered the question about the slipstream technique, and probably you can search this in PubMed and also in the Q&A box. Dr. Puich already post the link to your article. Okay, and there is a question that you already answered on the chat box about the using of balloon trapping in the same guiding catheter, and you mentioned that the resistance of the microcatheter will be increasing during the retrograde or channel tracking, so it may cause channel tracking failure if you use trapping balloon in the same guiding catheter, so we should better use two guiding catheter. Okay, and it's more convenient. Okay. Okay.
Maybe I want to ask to the Dr. Anek about the lumen catheter. Is it okay?
Yes.
Yeah.
Yes.
Dr. Anek, so how frequently will you use the Roman catheter in the usual situation, bifurcation, also in complex PCI? So actually, in Japan we often use, but so in foreign country except for Japan, the double lumen catheter is not so measured. How about in Thailand?
In Thailand, I don't know the other center, but in my center, I almost always use in case of large bifurcation and for the left main PCI bifurcation, I use almost nearly 100% for the case of left main bifurcation. And sometimes I use for the accidentally went into subintimal space, not only CTO lesion, but sometimes for the dissection, and the main Y is in the subintimal space, and I need to rewiring to cause a two lumen. I need to use a double lumen catheter. So, in my experience, I use a lot of dual lumen catheter in routine practice.
Yes, thank you so much. Actually, I completely agree with you. It's a very, very convenient catheter. So in daily practice, so I hope that this catheter will expand in the whole Thailand.
I agree.
Okay, thank you very much. So maybe we can move to the case presentation, and after the presentation, we will pick up the question again, and you can answer it later. So next, let me share my screen. So next speaker will be Dr. Pulish Suranchupakon from CTOPCI Institute of Thailand. So you have 15 minutes for your presentation. Dr. Pulish, please.
Okay. Good afternoon, everyone. Good afternoon, Chairman and panelists. It's nice to discuss with you today, and thank you for inviting me to share my case today. Okay, so every panelist is my teacher, so I learn a lot from all of you. So, so my case is a 22 years old male, risk factor hypertension, dyslipidemia, and he presented with a chronic stable angina for 3 months, and exercise status positive at moderate workload. Echo was shown ejection fraction 50% with anterior wall hypokinesia. This is his current medication, and his kidney function is in the moderate range CKD stage 3. And it is his cholangiogram. As you can see, there are band-stump CTO of osteal LAD, which quite ambiguous to find the osteal CTO cap. And this is his RCA. There are very well formed and large collateral from RCA to the LAD. So this case is a 50% restored main stenosis, and CTO at osteal LAD receive collateral from RCA. Left circumflex have minor disease, around 50% dyskiniosis at mid circumflex. RCA is irregular but not significant stenosis. So what will I plan to do besides in this case? Integrate approach with IVAS guide or begin with Leutoget technique. So I use Asia Pacific Zero Carb 2019 guidelines, same as Dr. Manpet showed before. So I feel that this case proximal cap of osteo-LAD is quite ambiguous. So I think I will use the IVAS guide entry and then try to puncture the two osteo cap. And if I fail, I will try to use the collateral channel, which is quite large and well formed from RCA. Okay, so I will begin the step like this. So I perform using a Sven-French JR4 90 cent at live femoratory and Sven-French EBU 3.5 at left femoratory and perform bilateral injection. As you can see, there are some gap in the CTO, and the proximal cap is quite ambiguous, and the distal cap is also blunt and also have a large side branch, septal and diagonal also. But I think this case the CTO score is probably 2, blunt NT shape, and occlusion range is quite long. And maybe I fail this time and increase the score to 3. And maybe I consult Dr. Nick and Dr. Kinoshita to perform the case for me again. So from integrate, there are 2 vessels for IVAS guide. There are RI here and the circumflex. So I think that RI is better compared to the circumflex to identify the osteo CTO cap of the LAD. At that time, I think that if I can identify while pulling back from RI to left main and I identify left circumflex, at the point I might identify the proximal cap of the osteo-CTO LAD. So this is pull back from the RI, as everyone can see. This is a circumflex here, and the LAD is opposite of the circumflex entry. And the left main is quite calcified and some thick fibrous part. So when I change the view, I think the circumflex is here and the LAD is opposite compared to the picture. So the puncture point might be here. But I try to puncture at the proximal cap of the LAD, but I fail because there are a lot of calcium at the left main and the angle is quite acute, so that I cannot shape the Y and puncture just opposite of the circumflex. At that time, I use a guide second, but it failed. So I perform Microcatheters approach using the Xiong with 150 cent caravelle to the distal PDA. The collateral channel is quite tortuous, but it was large. And this one is the Xiong Y. Okay, the Xiong Y go in and the caravelle is out here and try to support the Xiong go inside. As Dr. Kinoshita lectured before, caravelle have a taper entry point and the distal outer diameter is small. At the time, I think that maybe caravelle is slippery and can put inside compared to the coarse apple, but maybe Dr. Kinoshita will teach me later about this case. Okay, so compared to other microcatheter, caravelle is a 0.48 entry, distal sharp is 0.62, corsair is have smaller entry point, but distal sharp is larger compared to the caravelle. So from Microcatheters approach, I can I try a second, but the Y going out here to the I don't know where did it go. It went, so it's quite outside. And I try Miracle 6 to go in, and it's still going outside. And then I finally use a second to puncture in. When I try to puncture several times, patients feel pain, and sometimes they hold their heart that feel pain, doctor. I'm not sure that it is the guy that I go to the long tag or not. However, after I try several times, the gas second can go into the left main. This is the first time that gas second in. This is the Y in the RI. The first time, as you can see, the gas second going out to the long way, to the subintima of the left main. So I try again. And then gas second is going to the two main. So I can pass to left main and pass to the guiding catheter, and then I use balloon tap Y and continue to push caravelle in. Okay, after that I use a conventional Y externalization using the RG3 and begin to balloon with a 2O balloon, PD allowed 10 to 14 ATM along LAD. After dilatation, there are some slow flow, but patient is unstable, so I continue my procedure. So I begin to IVAS to check that RGT is all in the true main. This is the IVAS pullback from the LAD. Okay, so this is the Y in the RI back into the left main. Because I try to puncture several times, so there are some intermural hematoma from the Y that I try to puncture to the left main. But the main Y is in the true main, so I think that I can put the stent in now. So I stent using a GO33 13 stent at the mid part and T.5 23 13 stent at the proximal part. This is the result of the stent. The circumference is already gone. The patient feel a lot of pain. At the time, I try quickly to put the Y into the circumflex, but it's very difficult and I was fail several times. So I plan that I will use the, because it's difficult to Y to the sideband, so I think I will use the proximal optimization technique, dilate the proximal balloon to larger. Or maybe if it still fail to Y in, I might use small balloon to the fake Y and dilate to open flow because patient have a lot of pain now. Or use a small microcatheter to circumflex Y to open flow, or use the balloon main catheter to facilitate rewiring. So I choose the number 1 and number 4 first. So I port with a 408 NC balloon at 24 ATM and rewire using 5 course and Xiong Y. And as you can see, someone removed my protective circumflex Y to here. And the Y in the circumflex go out. So I open the Sasuke and use the Lantu hypercode and try to Y again because I afraid that the Y might go outside of the stent and make the stent distort. So I think everyone learned the lecture from Dr. Nick about the Sasuke before, so I passed this slide. Okay, so after that I can pass to the circumflex. I use a 1.5 15 balloon and dilate at the osteocirc 12 ATM, and then increase to 2.5 12 NC, and then TO 18 NC up to 24 ATM. And then I begin to post-dilate at the LAD again, using TO and CLAD 20, 20, and 20, and kissing with TO and 2.5 NC balloon at the LAD and circumflex, respectively, 14 ATM. This is the final angiogram. So the flow to the LED is going back to the RCA. And the circumflex look good, so I didn't perform anything else. I also do the IWAS, final IWAS, but I'm sorry that I didn't bring the IWAS to show today. So summarize my case. My case is PCI to CTOLD left main, little-gate technique, and using a wire externalization to writing stent with phenol kissing, balloon, and pots. I was guided several times to confirm two men, and total contrast is 240 cc. So my learning point is that in ambiguous osteoCTOLD imaging is mandatory. I was guided anti-gate PCI is very useful, but sometimes limited by angle and calcify. CTO tools knowledge such as Microcatheter and wide increase confidence for operator and chance to successful PCI. So my case is not quite complex compared to my teacher case. So thank you very much for your attention.
Thank you very much. And may I ask one question?
Yes.
Could you go back to the diagnostic angiogram, please?
Okay. Bilateral injection?
No. The left Korea angiography.
Okay, that's right.
Okay, the spider view. Okay, I see. And could you go back to the IWAS after you did the externalization, please?
IWAS, okay. Oh, not this one.
That is after the externalization.
Okay, this one. I got to.
So here I'm not sure, but I don't know why. I think why I see is like some membrane between the IVAS catheter and the guide wire in the remus, right? This guide wire is in the remus intermediate.
Sorry, I yes, in the lemmas. Sorry.
This one in the remus.
Yes, in the lemmas.
And the IVAS is performed over the RG3, right?
Yes, RG3. Yeah.
But I'm not sure, but I think why there is some membrane here.
Yeah, I quite agree with Dr. Manpet because this is a membrane. So that's why when you put the stent, it's no leafo at the side branch.
Yeah, I think this caused the abrupt closure of the side branch. Right? Maybe can we have your opinion? Okay, we should accept it. I think it's the very important point that Dr. Puris put the IWAS for monitoring of the retrograde guide wire in the left main. It is very important, and we should do this. But in this case, in this case, I'm not sure that it's in the same lumen or not.
So Dr. Kinoshita Sensei, what do you think?
Yeah. Yes, so thank you for a nice presentation. And this IVAS, there may be some team member between the LEMS branch and left main to the LED. So actually, in this procedure, there are some problems. I think. So in the just proximal, or in the city of the just proximal LAD, only retrograde wiring is very risky, because in many cases the retrograde wire often make a big dissection in the left main distal bifurcation, like this. And after putting the stent, the circumflex you often occluded. So in this case, if I were operator, actually, you said that it's very difficult to integrate wiring, to even when you use IMAS guided. But if I'm operator, once I close to the retrograde wire to the left main bifurcation, in that time, before penetrate the LAD proximal from the retrograde wire, I try to integrate wiring once again. Because if the wire close to the occluded part in the proximal LAD, maybe the IMAS from the antegrade, that by the IMAS image from the antegrade, we can see the tip of the retrograde wire in the IMAS, and we can correct the. We may correct the. We may choose the correct direction from the antegrade. And moreover, so once the retrograde wire come up to the very close to the just proximal of the LAD, so in many cases the plug characteristic or anatomical characteristic a little bit modified by the retrograde wire. And so first, when you try to the antegrade wiring at first time, it's very difficult. But after crossing to the retrograde wire to the just proximal to the occluded part, sometimes the antegrade wiring become easier than the first attempt. So the CTO case of the LAD proximal with the left main stenosis, it's very risky to accomplish the procedure using by only retrograde wiring. So we in such a case, in like this case, please try to antegrade wiring again and again and again, and to make a connection in the CTO region, not left main. It's a very important thing. So if you can advance wire from the antegrade, maybe the in our image, we don't see that we cannot see the some partition in the left main like this. So maybe you can preserve the circumflex during the procedure.
Okay, so you mean that so when the retrograde wire get close to the left main, we should do the anti-grade preparation and probably do a reverse cut in the LED rather than do the direct crossing into the left main.
Yes. Actually, the direct retrograde wire direct crossing, in some case, it may you may think that it is very easy in this case, but retrograde wire is almost uncontrollable. So especially like this case, the left main had a very severe stenosis. In most cases like this, the retrograde guide wire usually migrates the subintimal space in the left main. And once we made a big space in the left main, so it may cause of the occlusion of the circumflex by itself before implantation of the stenting from the left main to the LED. So there is a very risky manner. Just only a direct crossing to the from the retrograde in the left main bifurcation, in the left main distal bifurcation, including the chronic total occlusion.
I see. Thank you very much. And I think Dr. Watson, you already mentioned in his presentation that we should be very careful when advance the guide wire, especially the stiff wire, retrograde wire into the left main, right?
May I ask Dr. Purit?
Please.
Dr. Purit, did you do the anti-gate wiring first, or just proceed to the retrograde?
I performed the anti-grade first, but may I show you this picture? So because the proximal to the osteocap of the LD have a lot of plaque from IVAS and calcium, so I cannot put the wire inside like this because the angle is quite almost 90 degrees.
Why don't you use a Sasuke at the first time?
Sasuke.
So actually, I think this case for retrograde approach is very risky because of this is only one collateral channel, the main collateral channel. If any problem occur, like some dissection or even just only accordion effect can cause severe chest pain or hemodynamic collapse in this case. So you should be very careful because of, this is the only main big collateral for the LV function. So in this case, I think it's better to try to use anti-grade first before.
Dr. Anek, do you think that this case is the good candidate to do the slip stain technique?
I want to say that also.
I think it's better, is candidate for Sasuke. for the Sasuke catheter.
Okay, thank you very much. Thank you very much, Dr. Purish, for your nice presentation. So I have some questions from the audience. So you can see that in some case we have to use the epicardial channel. So I would like to ask you about the choice of the microcatheter in the epicardial channel. Is corsair prohibited in the epicardial channel? And how about the apical channel, like in case of Dr. Purish? Do you have any comment, Kinoshita Sensei? Kinoshita Sensei.
Yep. So in the Picadet channel, most Picadet channel is generally to say that it's very typically it's a very tortuous and and it has a very acute bending. So I think that the soft and sleepy microcatheter is better. And fortunately, the most Picadet channel has some diameter that is not so small in most cases. So I think the Carabel or my first choice is a Carabel or Corsair XS. The Corsair Pro is a little bit larger for the Picadet channel. And fine cross also better, especially in the so as Dr. Alex said, in this case, if we pass through the microcatheter in the Picadet channel, and to do that, if the patient have some symptom of the ischemia, at that time we have to change the more thinner microcatheter, from Corsair to Carabel, from Carabel to fine cross. So totally when I consider the Carabel is better for the first choice.
Can we talk the microcatheter in the epicardial channel, or just push forward only?
Yeah, but sometimes we need rotating motion because it's very tortuous and it has a very severe, many severe undulation.
Okay. And I have one more question from Dr. Jeffrey, asking Dr. Kinoshita, when you park the reverse catheter and with the occluded LED, where do you aim your step wire to penetrate into the LED, directly opposite to the reverse marker? Or not? Will that be an accurate statement?
Maybe for antegrade 3D, I try to use first of all, I will start to use ultimate broth tree or miracle 3, Miracle 6, Miracle 12, because in such a case, the Gaia series is a little bit difficult to use for the penetration of the just proximal LED. Tapering in such a situation, the from anti-gravity tapering wire is not enough to transmit the penetration force. So ultimate Bros 3 or Miracle series is better for the anti-gravity.
Okay, but I think he wants to know about IWAS marking.
IWAS marking.
Yeah.
Yeah. So as you said, the strip stream technique is one of the good indication for this case to the to find out the LED entry point.
Okay, and does Dr. Anek have any comment on IWAS marking and penetration? Can I hear your opinion?
Sometimes it's very difficult to find the entry point of the CTO. So IWAS is help a lot, and for this is a bifurcation of the main band CTO. So I think the first I will try just only for use the dual lumen catheter first, and then if they're not success, maybe use IWAS guided, like the Kinoshita mentioned. Like.
And when we do the IWAS guide of marking, I think maybe he wants to know that which part of the IWAS marker that indicated the image that we see, the middle of the marker or the proximal end or distal end of the marker.
It's quite difficult because I think it's a move a lot. So in my practice, I usually use like biplane simultaneous fluoroscopy, like the TD wiring, more than use IWAS guided, because we have to know the direction of the tip of the guide wire where it's going go to the two direction or wrong direction.
Okay, and I think we already answered the question from the attendee. For the slip game technique, at least we have to use a 7 French guiding system, right? 6 French is not compatible, right? At least 7 French.
I answer instead of Dr. Kinoshita. Dr. Kinoshita have the comment at the conclusion of his journal that Sven French for Sasuke and Opticos. But if you want to use other double lumen or other IWAS, you should use egg French.
Okay, thank you very much. So I don't have any question from the audience. So do the panelists want to ask more question to Dr. Kinoshita? Dr. Puris, do you have any questions?
Actually, I have a lot of questions, but maybe it's too long. But I like Dr. Kinoshita technique slip stream because he showed me before. But when I try to copy his technique, I was broken. So maybe may I invite you to come to teach us again next time. Okay.
Yeah, I hope so. Actually, Yeah, thank you for the inviting me in this session. Actually, I'm sorry that I could not visit your hospital in this year. But next year, I hope we will work together again.
Okay,
So
thank you.
nowadays we have so many cases. C2O waiting for you to come in to do the PCI in our center.
Thank you so much.
Okay, after the COVID-19 outbreak, I think we will have a chance to see each other soon. I hope. So today, I would like to thank all the panelists and all the attendees who stay with us until the end of this webinar. And I would like to thank Asahi Intech for organizing this educational webinar. And I hope that we can have this educational session in the future. And so today, thank you very much and have a nice evening. And please take 1 minute to do the survey question because we would like to know your opinion. So thank you very much, everybody. Bye-bye.
Okay, thank
Maybe
you.
we should take a photo first. We want to take a photo while smiling. Okay, everyone please smile. Okay, 1, 2, 3. Okay. Okay, thank you.
Okay. Thank you.
See you next year.
Bye-bye.
Thank you เทนเซสวัสดีครับสวัสดีครับทุกท่าน
คุณอาจารย์ทุกท่านนะครับ
ครับ
คุณอาจารย์อเนกอาจารย์โจ้อาจารย์มินเนอร์ด้วยครับ
ขอบคุณครับ
ขอบคุณครับขอบคุณอาจารย์ทุกท่าน
ขอบคุณอาจารย์ทุกท่านครับสวัสดีครับ